And now I have the great pleasure to introduce our keynote speaker, Dr. Loretta Christensen, an enrolled member of the Navajo tribe who serves as the Chief Medical Officer of the Indian Health Service. The IHS is an agency within the U.S. Department of Health and Human Services, is the principal federal healthcare provider for American Indians and Alaska Natives. As the Chief Medical Officer, Dr. Christensen is IHS's lead expert on medical and public health topics, giving technical consultation and guidance to the IHS Office of the Director and IHS staff throughout the country on American Indian and Alaska healthcare policies and issues. She provides national leadership for clinical and community-based health programs of the agency and serves as the primary liaison and advocate for IHS health professionals. She will clearly bring us just an incredibly diverse perspectives from her time as a trauma surgeon in New Jersey to her time in Gallup, New Mexico, running the Indian Health Service. So with that, please, Dr. Christensen, thank you.
Well, good morning, Yat-e. So honored to be here with you, and I hope to give you an interesting tour of the Indian Health Service and how we serve what I call rural and extreme rural America. So there we go. This is a beautiful picture of Canyon de Chelly. Some of you have been there. That spider rock has much historical meaning, which we can't talk about now. But I just wanted you to take into where I grew up and what I knew of before I went away to college in the East Coast. So our mission is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. This has been our mission for a very long time. We do get a little pushback now and then that we need to update it, but it really, to me, is a very holistic way that we approach the way we care for our patients. And for me, that's very personal. So quickly, just to give you an idea, we have 24 hospitals, 22 of our tribal partners. You can see all the health centers there, Alaskan village clinics, which are quite unique, which I'll touch on briefly. And we also fund 41 urban-centered organizations. So we provide a comprehensive health service delivery for about 2.7 million identified American Indian Alaska Native patients. Now, I say that because I think our population is much larger, but we're not gathering. That data is very hard for us, and it was extremely hard during COVID because a lot of people only put one down, one race or ethnicity, or they didn't ask. So we did lose some data in that. We serve 574 federally recognized tribes. I will tell you, during COVID, we served, it didn't matter if you were recognized or not. If you needed something, we provided it. We have over 15,000 staff. You can see the relative breakdown there. And I do want to say to you, though, if you're familiar at all with self-governance, that 54% of our funding is given to tribal organizations to self-govern, to run their own healthcare. We provide technical assistance at all time. We'll respond to any crisis they might have to assist, but it is them running some very, very well throughout the country, and we really appreciate the work that we do, and we have a great partnership with them. I do also want to say that 74% of our health workforce is American Indian and Alaska Native. So when I am actually applying what I'm saying to you, the reason it matters both at the community level and at the healthcare staff level is because they're one and the same many times. So I like this. We frame this as a quintuple aim, and I had to say, okay, we're going to keep adding these till we're out of places to put them probably. But I was interested in touching on some of this with you today to frame out what happens with our workforce. What can we do as leaders to support them? So improving population health. Well, you think, well, that's just the way we do our care and how we provide for our patients. But how we do this has a huge impact on our workforce. Are they invested in what we do? Are they part of what we do? Because if you're watching this, if you're watching that we are not producing good health care, you're probably not going to stay working for us. You won't be invested. You won't believe in what we're doing. So I have to look at this as both our work staff and looking at our teams, and then looking, of course, as our patients, which is the center of everything we do. So access to care. Can you get the people in that you need to? How frustrating it is to a provider to know there's 100 more people in their panel that they didn't get to see. Patient-centered work teams, which we're going to talk about, which is a huge project for us, the innovative work projects that we're doing right now in the Indian Health Service. Community care. We are forcing our care out to the communities because when we look at our facilities, and you saw we have 110 probably in our federal side, how do we get the care to everybody that lives in those populations? They live miles away. There's no roads. In Alaska, you fly in, that's it. That's how you get care. We just recently, I'm proud to say, opened a brand new clinic, and I'm sorry I don't have a picture, Supai Clinic in the bottom of the Grand Canyon. You hike or you helicopter. Okay. And I will say a lot of the team helicoptered in for the opening. I hot offloaded too many helicopters in my trauma career, so I waved to them. But it was a fantastic opportunity to see that's rural care. That's rural healthcare. But how do we support them in the bottom of the Grand Canyon? So is the care culturally appropriate, delivered with cultural humility and sensitivity to the native language? We also did studies that showed our patients, even though they spoke English, 60% understood better in their own language of what to do, medical instructions, how to take medications. So we have to blend that into everything that we do. Are we speaking to people so they hear us? Strengthening preventative care. I think we should be a preventative care public health service that we were intended to be, and we're working very hard to bring that infrastructure back. And then tribal customs. And the reason I say this is because when we try to retain providers, some of them will go, they'll leave and you'll go, well, what happened? They said, well, the patients don't like me. Well, the patients are used to this revolving door of people coming in and out, so they're not going to trust you for at least a year. And so we try to tell new providers, don't get your feelings hurt. They probably are waiting to see if you're going to leave. And then when you tell the providers, they're good, okay, I got it now. And they build that relationship to get to that other side of those patients saying, I want my provider. And they do. And they do come around, but they just feel like they're left all the time. So again, you have to understand the culture that we're serving. And I think you'll get a great deal back from that. So then one of the others is advancing health equity. I will tell you, I fight this all the time. And we're going to say, everybody knows about equity, Dr. C. And I'm going to tell you, not really. And I have these conversations with my headquarters colleagues all the time. Do we have foundational equity? Example, I'm meeting with the White House EOP, and they're very happy because they're going to send out, free test kits. And I said, do you know, no, most of my population has no addresses. They just look like, whoa, like I just punched them. And they go, oh, we should have asked you. Yeah, that's foundational equity. When you set out to do something, you need to be at that foundation, at the table, to say, we only have post office box, or we only have a community center, or we don't have addresses. If you look in our records, it's going to tell you the second house with the green roof by the juniper tree. And that makes sense to me, but I don't think it makes sense to a great deal of other people. Inclusiveness, lessons learned during COVID, what was missing? We weren't at that table, and we had to hustle to catch up with getting a jurisdiction for vaccinations and other things like that. We're going to talk about moral injury a little bit later, and I'm going to just jump on communication, because that is going to end up being one of the most important things to retention of workforce. They cannot feel like they're someplace over there and I'm over here and they don't know what I'm doing. That is just disenfranchises everybody because they don't care about me. They're not listening to me. I know what's going on and they do. It's absolutely true. But what is the sweet spot of communication? I am still searching for it, by the way. I send out IHS all. I have town halls with providers and other groups. I ask for feedback from the ground, because my priority is every advisory committee of our agency has to include ground service unit people. Always. Because those are the people delivering the care. And I worked through IHS that way. I was a surgeon at Gallup Indian Medical Center. Then I was a clinical director. Then I went to the regional area office in Navajo, and now I work for headquarters. I feel like I have, I hope, a balanced view of what each of those things mean and what communication is necessary. I'm sure we can always be better every time, by the way. And then empowerment is what they say being heard And are we incorporating that into what we do? And the answer should be yes. It should just be yes. So I love this drawing, and you've probably seen it, but I have to play this at everything I speak to because I want them to understand we're not talking about equality. We're talking about equity. We're talking about health equity. And if you think this doesn't weigh on your workforce, it does. I can't get that for my patient. I wish I could get this for my patient. They just feel helpless at times if we can't achieve some of this equity for our patients and for them, those that are taking care of them. So social determinants of health, the way I always put it is we have all of them. And we always have. And so when we look at it, we always operate in this realm. Anything we do for our patients, we're already thinking about this list. And this is an abbreviated list I'm showing you today. So how do you address this in the pandemic, which I'm going to talk about in just a second, because it's there already. And then you know it's going to get worse when you are challenged by a public health emergency. So lack of running water. I was chatting with someone before the meeting started, and that was something how many years ago? Can you turn to each other and say, in this United States, you still have populations with no running water, and believe it? When I tell my former colleagues on the East Coast, because I worked for private sector for quite a bit, they say, oh, come on, you can't be serious. And I'm like, no. So how do you tell people to wash their hands and disinfect their house when they don't have water except from a tank that they have? Well, we found ways, to be honest with you, but it is different. And then how do you look for basic utilities to run nebulizers, CPAPs, anything like that with no electricity? And I'll tell you what you find. You find very long extension cords because of the one house that has the power. You're going to have 10 extension cords going out from that house to their family homes, which are typically on the same land. And that's how they share the one electric that might be coming in. And then, of course, broadband. 70% plus of our telehealth visits were telephonic, cell phone. Worked well. It quadruplated, if you will, during COVID that we got these people through on telehealth, but it was by phone. Broadband is it's getting better, but we know still almost 50% don't have reliable access to it. Our children were going at 5 in the morning in a pickup truck to get the best spot on a hill to get their school because they could get the best signal there. So you'd see all these trucks lined up on a mesa or on a mountain to try to get the kids to be able to hear the school. Food insecurity. Navajo Reservation, 27,000 square miles, 14 grocery stores. Do you know how far you have to drive to get your groceries? And then you know healthy, healing food is expensive. So you have the issue of poverty. You're trying to tell them 14 days of food to keep isolated and keep their families from, congregating. And you have to drive 2 hours to go get that food. So we had massive food delivery, by the way, during COVID. We took millions of boxes of food across the agency. And then, of course, health literacy. And I'm going to say health literacy is challenging for all ethnicities and races because when you start talking medicine, there is this blank look, especially cancer, when you start speaking about cancer. So the challenge of this is profound, is to find that health literacy. And that also is important to our providers. How can they communicate? Do they feel they're getting through? This means something to them that's very, very important. So enhancing the care experience. Why was our care during COVID so extraordinary? Because purpose became the driver. And I'm going to tell you right now, purpose has to continue to be the driver. We had at one time in the first surge of COVID, 4.8 more deaths, almost 4 times more hospitalizations, and 3.5 times more cases. Navajo Nation was the highest of all the 50 states in what happened during that first surge. Okay, so, and we were all grappling with, of course, how to treat COVID properly. So I will say once vaccinations came, we became the most vaccinated. We, right to this day, are still the most vaccinated 65 and over because that was all we had to fight this. And we had innovated, adapted quickly, which we're used to doing. It was a complete collective energy of our entire staff. And it was always creating trust. Now, how do you create trust with the American Indian Alaska Native population when we're the government? Imagine that duplicity. I'm standing there saying, please trust me. And then I'm going, I'm really sorry what happened before. But it was essential and critical that we did that. And everything we said was on a level of to the community. This is what we're doing. This is the vaccine. We're going to get it in front of you. We're going to show you this. And it did work, by the way. But the bottom line is that trust, if we didn't get it, we would have been struggling like the rest of many in the country to try to get vaccinated. And then staff engagement. How do we keep people working? Purpose. They were so driven by not letting their patients die, not letting them get ill. They worked. I can't tell you how amazing they were and are. So what can we do to help them then with the burdens that we have in rural areas? We don't have a lot of staff. We don't have all the specialties this beautiful place has. And so how do we make up for that? Or how do we do better with that? So for us, it's innovative work teams. We've been working on this for almost since I've been at headquarters. And so what we did create, my great number two in Navajo, who's now with me at headquarters, came up with public health aids. She says to me, we need to pivot to all these domains: surveillance, case management. We do community-based cancer screening, colorectal cancer screening. She trained all her staff, her 50 contact tracers, to do all these things. So when the STI outbreak occurred that you probably all know about, they were following up, they were calling, they were getting people in to get tested because they had been taught all these domains. So we said, hey, we're going to make this a position. So we do have a career ladder for this now to get new people into our system, to empower community people to become these aides, and then hopefully get them in our system and retain them by making them an important part of our teams. So this helps our public health nursing. This helps the docs because they get information and feedback from the communities. And so this is something that we are evolving right now. Training and education about public health, where does that most important? To our community members. We need to teach them, when you see this, this is hantavirus. When you see this, this is maybe TB outbreaks, which we still have, by the way. We want to assist our patients with their appointments. Are they following up? Because you know what? No news is good news in Indian country. So you have a cancer test and say it's positive. They say, well, nobody called me. I didn't hear anything about it. We're trying to teach, you need to follow up. You need to demand the care that you deserve, and you will help you advocate. Okay, so we're empowering our patients as well. Coordinate with our providers, PHNs, and case management. We have all of our facilities are certified as patient-centered medical homes, which means, of course, everything leads back to the patient, as it should. And we want to increase those teams so that our nurses do nursing and our doctors do doctoring, or our APRNs and PAs do their care, because they're doing everything right now. They're answering the phone, they're following up, they're doing things like that. And then we want to bring our families in and begin educating them on how they can support their family members. So we need to get them involved and then ensure our follow-ups. So now, what do we do for our teams? Well, reminding you again, I work for the US government. We have a lot of restrictions on what we're able to do for staff. And I'm not saying giving somebody an umbrella with your logo on it makes them happy, but it is a gesture that, you know, private sector uses a lot. We don't do those things. And in fact, if I was honest, we're not even really supposed to buy them a cup of coffee or anything, but we can be giving them continuous awareness of what we're doing. We can involve them in everything we're doing. We acknowledge them all the time. I don't do the work, you're doing the work. What do you think? What else can we do? Give them as much support as possible. During COVID, we kind of switched off vacation times, like we'd let somebody go. Then we try to make them all peel off and take some time while the rest of us covered. Communication, again, that is to me the most important. And we now finally have created our employee wellness program driven by the workforce. I was in integrative medicine during my career, and I took care of the caregivers for 20 years, but they need to do it. they need to tell me what they need. They need to tell me how I help them find that balance again between our lives and the work that we do. So this is great. I mean, I'm so excited about this. So let's look at that moral injury just for a second. And because I think this was so bad during the pandemic, because you saw people dying, you couldn't help them. We all knew they were dying alone. None of us could help that. So all of this was even worse for us in our Indian country, because we left the largest number of orphans from the death of caregivers during COVID. Look at that moral injury. How do I tell a provider, I'm so sorry, and thank you for staying with us, and thank you for giving all that you gave. So this drives us. This drives us to do better and to do as much as we can. I'm going to be a little technical for a second. Our vacancy rate in 23 is, you can see it's pretty high. And you know what's bad is that when I look at the overall, I'm like, hey, we're not doing too bad this month. And it isn't, because we are getting the care out. If we were fully staffed, obviously we get more care out, but we are surviving in most places. The reason I show you this is because we held in 2020, we kind of held lower numbers. People didn't quit during the pandemic. Okay. They stuck it out. People canceled retirement. They helped us. They supported us. And then when it was done, you see in 23, and it's not done, but the PHE ended, then they retired, then they took other jobs, and then we couldn't retain them. But for that 3 years, they did not leave us. And so what was that about? Well, I do look at salary tables. I do try to support those things across all of our agency, but that's not it. When I have town halls, they tell me everything, and I want to hear everything. It's a safe space. But at the end, they go, but I have to tell you, this has been the greatest privilege of my life to do this mission. Okay. So when it got down to it, it is what they did from their heart and soul that meant more. So how do I support that? How do I help support that? And here's another one for May. You can see we stayed there in 2020, and we started to drift off in 2023. So our employee wellness team, it is a whole health program. We're just in the first stages. We track what's called the Federal Employee Viewpoint Survey, because there's specific burnout questions that we track and try to address. Strengthen our culture of care. We're trying to institute well checks. All the supervisors of providers have to at least once a month do a well check on their staff. We had a lot of trouble with suicide. We lost a couple of doctors during COVID, and we've really stepped up our suicide screening. I speak a lot to providers about not being afraid to ask that question, not being afraid to ask for help. So we really have augmented that. We've increased access to anonymous counseling where nothing's recorded. They're not afraid of any repercussions. I have told them, I will back you. If you have to go out for mental health reasons, I will help you get back. We will advocate for you, because that is a huge fear in our provider population. And then our multidisciplinary team for employee wellness. So in summary, your staff is your greatest asset. Our greatest honor is serving our patients. Communication, I said town halls, my emails, posting on what I keep asking them, how can I get to you? How can I get this information to you? Acknowledge who does the work. Leadership has to blend with, this isn't a hierarchy anymore. This isn't when I started medicine, when there was no computers, by the way. It's different now. It is a team. And we now say we're one IHS. That's all we keep saying. We're one IHS, because we want everyone to know they count and they matter. Nothing about us without us. And that includes your nursing staff, your provider staff. They need to know what you're doing. We have to collaborate, and we have to compromise sometimes, but we can get to okay with them, and be thankful and kind. We don't want to be that kind of leader anymore that tells people what to do, that says you must be this way. We want to work with what we have and just really use that synergy to continuously improve care to our patients. So when we talk about workforce, all of our challenges are different depending where we come from. This is what I know, is this is what keeps my staff, my teams taking the best care of patients, is to be acknowledged and recognized, communicated with, and to be thankful to them every single opportunity that we can. So this is very important because in Indigenous country, we look back 7 generations, what was left to me by my elders, and we honor our elders. But now I have to give 7 generations ahead of me a path, and we hope to give them the right path. And then this is another beautiful picture of where I'm from. So I say thank you, okay. And again, thank you so much for this opportunity.